Good evening, everyone. The topic for today is infectious diseases and tropical medicine. And the speaker that we have here is Dr. Anand Joshi. He is a consultant, intensivist, and physician at Gamman Hospital, Hyderabad. So, you can take over. Thank you.
Welcome all back to this fourth session in the series of the lectures on the infectious diseases and the tropical um, diseases. Uh, we were discussing about the tuberculosis, and as you know, the tuberculosis has a wide variety of applications. So we last time stopped at the treatment and the regime part. Just a quick cap on the few of us two slides which we spoke about the treatment. We are all aware of the first line treatment: isoniazid, rifampicin, pyrazinamide, and ethambutol, and we also know the standard regime of 2 months and 6 to 12 months, depending upon the disease severity. We also went through about the second and third third line of medications, especially the fluoroquinolones, injectables, aminoglycosides, polypeptides, ethionamide and prothionamide, and cyclosporine pass. We also went through few of the antibiotics which you might come across when the tuberculosis is detected, and they would be giving the sensitivity to. Those are the linezolid, amoxicillin, carbapenem, clarithromycin, and you would be a bit surprised why they are giving this, because at some point of time they were thought to be useful in tuberculosis, but they are no longer used in treatment, or they should not even be considered. There are few bedaquiline and delenamide new class of antibiotics which we will be going through. So why do we need a regime for treatment? So whenever you have a bug which requires more than one drug to control or kill, you need to have a kind of regime in place which will tell us what exact dose, what exact combination, and what exact duration of the time we should be using to achieve cure. Now, we know that the most common for the tuberculosis is a short course tuberculosis, in which we have 4 drugs for the intensive phase. Now, the importance of this 4-drug intensive phase, which is usually for the 2 months duration, is we try to attain as much bactericidal state as much as possible, and the patient has to become asymptomatic and non-infective. So that's the importance of the intensive phase, where you go all out and try to stop and kill all the bacilli. Then you continue this drug. Now you know that this tuberculosis bacilli is a very tricky bacilli. It stays inside intracellularly. It stays inside the body in a dormant phase and tend to come now and then. And it's a slow growing bacteria. So to eliminate those couple of bacteria which are stayed behind, and to sterilize, we continue with the continuation phase of the 2-drug, which would again be bactericidal drug, that is INH and rifampicin, for extended duration of time. And now for that, if you see if there is a culture positive or smear positive, you continue for 4 months. New culture negative case for 4 months, and then we have those things variable when it comes to pregnancy, which we'll be talking a bit detail later. Relapsing and a failure treatment again has a bit of a different, slightly different regime in terms of addition of streptomycin. Then you have a failures, and then you have a multi-drug resistant and XDR TBs. Now, the standard short course tuberculosis regime of 2 months and 4 months should, and if the bacteria, and assuming that this bacilli are sensitive to this drug, 90% of the patient gets cured in these people. 10% get left out with various reasons that we'll cover later. So if you're using this, if you get across somebody who's got a tuberculosis and who's fitting into a regular straightforward criteria, remember that these 2 months and 4 months are enough. In 2 months, you should get your patient asymptomatic and non-infective, and the rest of the 2 months would sterilize the patient. Now, that regime. We use it for the daily intake, but there, because of the various reason, the government also came up with, or the various authorities came up with, thrice a week regime. Now, though this regime is applicable for most of the general population, however, there need to be selection in this. It is offered to a non-HIV patients, and these people who are on thrice weekly regime, irrespective of that, are likely to develop resistance and treatment failure. So be careful when you are using this thrice a week regime. Now, what would be the reason and most common factor for developing the resistance or the treatment failure they found out was a lack of adherence. So just that the patient doesn't take the tablets, or it's the tablet doesn't reach to the bacilli. And what there are few factors, that is patient factors and the provider factor. In the patient factor, it's a lack of belief that this illness is serious, because tuberculosis is such a slow growing. It's like a termite, which is eventually going to eat you up and kill you. Uh, Also, this 4 drug regime is like, if you ask somebody to take 5 drugs daily and make a scene out of it, then the effect, even if you get an effect, you get 1 to 2 months. So at some point, this patient who are used to, say, feel better, and they would expect that it should be making magic in 2 or 3 days, they start thinking that whether this treatment is beneficial or not, and then they stop taking the medications because they say it's not working. Certain concomitant medical conditions like alcohol or malnutrition or drugs becomes a challenging factor. They forget the drugs, they don't want to have money, the poverty is there, there is a joblessness, homelessness, there is a lack of social support, there is social stigma. Oh, somebody's got TB. It's a big deal in endemic countries or in the Indian subcontinent. There is some role of the provider also. If there is no adequate funding, then there will be no one to provide. If there is a direct observed therapy, then and the person is not given his salary or paid his wages, then he will not go, and that the drug won't reach to the patient, and ultimately the resistance develop or the patient succumbs. Uh, the direct supervision therapy was one of the ways where the authorities and the various government found out that we can overcome the lack of adherence with that. And this seems to have improved compliance and decreased the failure, relapse, and drug resistance. So this is one of the most successful therapy, or the DOTS therapy they call it, direct observed therapy, which in which the patient is actually asked to swallow and drink a glass of water in the front of the worker. The third thing is, in this regime, important thing has come up is the availability of the fixed dose combination. So if the previously when they started, they had these 4 drugs to be given as per the weight, and then looking at so many tablets, of people would really become non-compliant. So the pharmaceutical guys came up with this a big tablet with a fixed dose combination, and that has surely decreased the dose related issues. So how would you look at this? So you started a treatment for tuberculosis intensive care, and then you go into continuation care. So how do you see for the response? Usually it is monitored by the culture or smear only. Repeating the gene expert or looking at the chest x-ray whether there is a improvement is there or not, it's not recommended, because gene expert and the chest x-ray doesn't resemble. Chest x-ray may lag behind a lot. Chest X-ray, however, at the end of the treatment, uh, can be taken as a comparison for the later, and that is acceptable. For those, now we know that this for the tuberculosis there will be sputum positive cases which with the pulmonary tuberculosis, and there is the extra pulmonary tuberculosis, miliary tuberculosis, where the sputum will be negative. For those who are sputum positive patient, you need to collect the sputum either monthly or at least 2, 5, or 6 months. And once the treatment is done, you need to have the final sample at the end of the treatment to document that it is cured. Usually by end of 2 months, 80% should be negative, and by end of 3 months, 100% people should have a negative sputum. Now, if anybody continues to have a positive smear or positive sputum, remember it's a sputum thing, not a gene expert or chest X-ray. The person, there should be a very, very, very high index of suspicion. You should evaluate them for a drug resistance, adherence, and if everything is and drug sensitivity, and if everything is okay, then it should be looked out for the failure or relapse. When you're giving the medications, you need to monitor for the drug reaction, especially with the hepatitis, which is a very, very, very common. And if the patient has got a hepatitis co-infection, again, that becomes very, very relevant. That you need to change the regime. You might have to halt the regime for some time till the enzymes come back. And now, out of rifampicin or INH or ethambutol, which one is the culprit? You will have to, in a stage-wise, reintroduce the medications and repeat the LFTs regularly, so as to catch any kind of hypersensitivity or hepatitis. If the patient develops arthralgia, particularly gouty arthritis or hyperuricemia, then the pyrazinamide is a culprit. If the patient is on a rifampin, not rifampicin, but a rifampin regime, then probably, and if it develops an autoimmune thrombocytopenia, then you have to stop that drug and you should not re-challenge it. As you know, ethambutol, you need to look for the optic neuritis, and you need to also look for the peripheral neuropathy, for which you supplement it with vitamin D. Now, when you will declare the patient has got failure or and relapse. So, treatment failure will be declared when there is a positive sputum culture at the end of 3 months of the treatment. So, intensive care, intensive treatment of 2 months plus continuation 1 month, and then by that time 100% should have negative sputum, and if it continues, then there is a problem. So in this situation, you need to urgently chase the drug susceptibility if not done, or send for the drug susceptibility. While waiting the drug susceptibility, you should at least 2 or preferably 3 drugs which are never used should be added. So continue isoniazid and rifampicin, and add 2 to 3 drugs extra pending susceptibility. Of course, once you get the susceptibility, you have to scale down and go back to the medications where the susceptibility is there. Now, if the patient is declared successful treatment or cured at the end of, say, 6 months or 9 months, whichever the situation you are, and then comes back with the symptoms, and then again gets a sputum positive, or you see that the sign and symptoms of the tuberculosis are back, sorry, then you call it as a relapse. Again, in this situation, you have to make sure that you have the drug sensitivity done and the patient has received the medication where the bacilli is susceptible. In this case, while waiting for this, if susceptibility is not done, then again, empirically, you need to have all the 4 drugs plus add streptomycin. Now, you have to choose the situation that if there is a less likelihood of MDR-TB, then go for 4 drugs plus streptomycin. But if there is a high likelihood of MDR-TB, you feel that no, this patient might have got a multi-drug resistance, then you have to go for other second line of drugs in addition to streptomycin. So what would be the MDR-TB like? So the MDR-TB is declared as the TB is declared as multi-drug resistance when there is a resistance to at least isoniazid or rifampicin or both. Now here uh, the whole the timeline for the treatment changes. It most of the cases it goes to almost 20 months, out of which 8 months are of intensive phase. And during this 8 months of intensive phase, because you know that rifampicin and INH are useless, we have to use this 5-drug combination. One should be fluoroquinolone, out of which levomoxy or gaticloxacin. Second should be an injectable, which would be amikacin, kanamycin, or you can have caprimycin. Third should be ethionamide or prothionamide. Fourth, cyclosporin. Fifth, pyrazinamide. Now, ethambutol can be plus minus. You can be added based upon the tolerance. Now, in this intensive phase, after 4 months, you can stop aminoglycosides. However, the total regime with rest of the drug should continue to almost 20 months. Now, remember when you are dealing with this MDR-TB, you are still going to monitor same sputum positivity, sputum and the culture, and make the smears and look for the cure. What about the XDR-TB? When MDR is a resistance to rifampicin INH. When you get the second line or any of the injectables or fluoroquinolones also, then you are looking at an XDR-TB, and which is a very, very difficult and extremely challenging situation. So these are the guidelines. This I have taken this guidelines straight from Harrison's textbook. So these are the guidelines for the patient with documented or strongly suspected XDR-TB. What it says is that use the pyrazinamide and any first-line oral agent that may be effective. So here your drug sensitivity comes into play. So you need to really chase those drug sensitivity and start with pyrazinamide and any first line of oral agent. So far, the resistance to pyrazinamide is not very common. So it is assumed that pyrazinamide is susceptible. Then use an injectable agent to which the strain is susceptible and consider extending the duration. So remember previously we in MDR we thought that we can stop injectables by 4 months, but here extend the duration to 12 months or possibly treat the whole time of period. Use the later generation of fluoroquinolones such as moxifloxacin and go to the higher dose of each of them. All second line oral bacteriostatic, that is PAS, cycloserine and ethanamide should be used, that has not been used extensively in the previous regime, or any such agents that are likely to be effective. Now, 2 new drugs have been introduced, especially for the XDR-TBs. On all this regime, you have to add bedaquiline, which I'm going to talk later, or delanamide, and one of the other following drugs. So that now remember these medications I spoke about previously, that they are not the first line of medication, but they can be used as an adjuvant because historically at some point they were the bacilli were susceptible to these medications, so we can add any of them. Now data is still sketchy because because they are still new for the bedaquiline and delanamide. However, simultaneous use at this moment is not recommended because we don't have much of information and the safety issues are there. If your drug sensitivity comes back and there is a resistance to isoniazid, but if it's a low level of resistance, MIC concentration you need to know, which I don't remember on the top of the hand, but if there is a low level of resistance, then you can go with a high dose of isoniazid. If there is a bacterial load is very high, especially in the pulmonary and the lungs are destroyed, not that nowadays we see, but previous we used to see a lot. You can go for pneumonectomy or lobectomy, and strong infection control measures needs to be
என் பொண்ணுக்கு
implemented.
வந்து அதெல்லாம் அப்படின்னு சொன்னாங்கன்னா நான் போய்
So,
நான் பொண்ணு மட்டும் ஒரு வீடு ஒரு 2 பிளாட் நான் எல்லாம் ரெடி பண்ணி வச்சிருந்தேன் எனக்கு ஒண்ணுமே கேட்கல வேலைக்கு போயிட்டு அதோட
முதல்ல போய் கேட்க கூடாதுன்னு நம்ம தானே சொன்னோம். அது என்ன இது சொன்னீங்களே, என்ன நட்சத்திரம்?
யாருக்கு என்ன வச்சிருக்கோம்
so in these cases, to remove what would be lack of adherence as the biggest factor, dot therapy, direct observation therapy, and full adherence should be followed up. I spoke to you about this deriphenoline antibiotic, which is a bedaquiline now currently, and delanamide. Bedaquiline is an antibiotic or antituberculous drug which currently is strictly under the government control. It is contraindicated for elderly, pregnant, HIV, and children, and the dose is 400 milligram twice a week, followed by 200 milligram 3 times per week for 22 weeks. So total duration of 2 years or 24 weeks is recommended. Then we have nitroimidazole group like delanamide, delamanide. It is still in a phase 3 trial. However, it has a safety concern regarding the prolongation and the hepatotoxicity. I spoke just now about the lobectomy and the pneumonectomy if your bacterial load is very high. Let's talk about a special situation. What's the recommendation about the children with bone and joints and meningitis and miliary TB is almost 12 months. You have to extend the treatment. In the chronic renal failure patients, aminoglycosides, ethambutol, unless the drug levels are available, you can use ethambutol, but try to avoid them. In mild to moderate renal failure and hemodialysis, isoniazid, rifampicin, and pyrazinamide are the drug of choice with a regular dose. However, in severe renal failure, we'll have to reduce the dose of INH and rifampicin. Now, those with the hepatic failure or cirrhosis, ethambutol, streptomycin, and fluoroquine are drug of choice. However, isoniazid, rifampicin, pyrazinamide, and isoniazid and rifampicin are not contraindicated. However, you have to be very, very careful regarding the side effect of hepatitis. Pyrazinamide is absolutely contraindicated in the cirrhotic patient. In terms of pregnancy, the duration slightly goes up. It goes to almost 9 months with 3 drugs for 2 months in the intensive phase. Now, for pyrazinamide, there is a bit of a controversy because WHO recommends the use of pyrazinamide is safe, but because there is no strong data, US guideline does not recommend. Streptomycin is an absolutely contraindication, and breastfeeding is not a contraindication for any of the TB drugs. Yes, it gets secreted in a very small quantity, but it has not shown to have any impact on the kidney. So how do we prevent the tuberculosis or the spread of the tuberculosis? The best thing is if you see any tuberculosis patient, you isolate and treat that case, that and stop the prevention. So by the end of 2 months, you should have a patient with a tuberculosis which is non-infective to other. The second, which was game-changing in the history of human mankind, was the evidence of the BCG vaccine, and it's been there since first it introduced in 1921. Now the BCG vaccine still has its original strain. Now in the current generation, the issue or the debate regarding the BCG vaccine is quite tricky because the efficacy has shown to be very, very wide. When I say efficacy, it's like whether it is effective, whether it's effective in prevention of tuberculosis or extrapyramidal tuberculosis or not. And when the data was looked into the various countries, various continent and various population, what they realized is that the efficacy of BCG vaccination decreases as you move away from the equator. So those countries who were around the equator, or the tropical countries, which we called, were having most effect of prevention by BCG vaccination. But as you go from equator towards more colder countries, Europeans, North Americans, or down south in Australian, it the efficacy was decreased, and even after the BCG vaccine, people used to get tuberculosis. Now, this is a very wide area, but as far as India is concerned, BCG vaccination has shown to be very effective, and it was effective in prevention of pulmonary and non-pulmonary TB. I remember in the last class we had one of our candidates, audience, who did say, and I don't exactly remember now whether it was prevention from non-pulmonary tuberculosis or not, but the data which I went through has clearly shown that there is a prevention. Of course, the efficacy is different, but in an endemic area, the prevention of pulmonary and non-pulmonary tuberculosis, particularly miliary and meningitis in small children, was more. Yes, this efficacy was less when it we were talking, or when the cohort, or when the population was more in a colder country or in a Caucasian. So for the BCG vaccination, once you get various side effects like local reaction, lymphadenitis. There is 1 in 10 lakh possibility that they will get osteomyelitis, and then 1 in 10, 1 to 10 deaths per crore of doses, mainly in the kid with a combined immune deficiency and HIV patients. Skin reaction which you get will wane with time, especially when you are dealing with the Caucasian, or the away from the equator population. The size of the skin reaction has no relation with the degree of protection. It doesn't mean that if you have a big mark, then you have better protection. Nothing like that. Also, it is the induration that is important, and not the erythema. So with this data, with such a wide efficacy, WHO recommends strongly to all the kids to have BCG vaccine in an endemic area, or the around the equators, countries in around the equators, and not, it doesn't recommend as a mandatory in a non-endemic area or away from the equator. How do you treat the latent TB then? Now, latent TB are mainly those tuberculous bacilli who are sitting in your body, and there is no way, there is no diagnostic test to say that this person is going to get an active tuberculosis from his latent tuberculosis, because it's all situational. However, if you know that these patients are got a latent tuberculosis, and then we can find the high risk group, and these high risk groups are recognized by the positive or MANTU test, or the skin test, TST, and quantiferon gold. So tuberculin test is a very popular, and based on the reaction size, you identify these patients, that these are the patients who will need the treatment for the latent tuberculosis. And what are those? Who are those patients? So the HIV infected, recent contact with patients with TB, organ transplant, those with the fibrotic lesions with consistent with the old TB, those who are immunosuppressed, those who are on high risk medications, especially the immunosuppressions, recent immigrants to a low prevalence country from the high prevalence country, injectable drug users, children less than 5 years of age, children and adolescents exposed to adults in the high risk category. All these people with the various size, like till the high risk medication more than 5 millimeter, and rest of them about 10 millimeters, all those people should be the candidate to treat the latent TB. Otherwise, you don't treat the latent TB. Now, when you decide to treat a latent TB, make sure that you are not treating an active TB, because here it will be 1 or 2 drug regime. And if you give an active TB patient 1 or 2 drug regime, then you are inducing a resistance in that, and it's going to be treatment failure. So make sure that you are ruling out any active TB. So what are the regimes we have? So we have first regime is isoniazid alone regime, where you give for 5 milligram per kilo, max 300 milligram for 9 months. And if it's an endemic, you can give it for 6 months. For the HIV patient in endemic area, you can give it for the longer period of 3 years. The second INH alone regime is twice a week for 15 milligram per kilo for 9 months. And the second regime, other regime is rifampin regime, where we have a daily daily rifampin for 4 months. The third one, which has been recently been introduced, is an INH plus rifampicin, that is 900 milligram of each regime. You give once a week for 12 weeks. However, it's not recommended for children less than 2 years, pregnant women, and HIV patient on ART, because there is significant cross reaction between the HIV drugs and anti-tuberculosis drug. However, those patients who are on efavirenz therapy are safe, and they can be treated for the latent tuberculosis with INH and rifampicin. A quick word about the tuberculosis and the public health. We know that DOT strategy and the contact tracing has improved the efficacy, and the amount of active cases and the new cases have come down. From the healthcare point of view, tuberculosis have become mandatory for the notifications, so you should be notified. And whenever you are suspecting any tuberculosis, so isolation, hospital airborne precautions, and special reverse air condition, reverse air circulating wards should be created, and they should be kept in isolation away from the other patients. So this is where I would end the session for the tuberculosis, and next time we would look into the non-tuberculous and some tropical. I'm open for any questions.